put us down, even for an adult. Till 16 years, the child cannot give independently a consent for the treatment. The child needs to be explained what the procedure is, get a verbal consent, but the final consent which is signed either for a routine procedure or a conscious sedation or a GA has to be done by the parent. After 16 years, the kid is independent to give the consent. We are seeing a lot of cases of child abuse in pediatric oral medicine practice. So legally, whether you're a practicing dentist, surgeon, a restorative, orthodontist, you're going to see children in your practice. If clinically you find signs, an unexplained bruise, or an injury or a trauma, the explanation given by the child does not manage what the parent gives, suspect a possible violence or a child abuse, you need to inform the concerned authorities. Because you try to miss it, the case goes somewhere else, it can become a legal thing for you that you have failed to diagnose, especially in the orofacial region. A bite mark or a trauma to the injury or to the lips, unusual findings, especially oral sexual practices which is arising in young kids. If you see an unexplained red patch or an erythema at the junction of the hard and the soft palate, the patient is asymptomatic, suspect something is going wrong somewhere, and carry your investigation in that aspect. Okay, so this is a tabular column taken from the Oral Diseases Journal, which is based on multiple clinical studies globally throughout the world. What's the maximum number of types of cases which is seen in pediatric oral medicine practice? Topping the list is aphthous stomatitis, HSV infections, traumatic lesions, geographic tongue, candidiosis, finally with tumors and commissural lipids. Unfortunately, India is not represented, so if there are postgraduates in this audience, it would be a good thesis topic just to do a survey. What are the kind of pediatric lesions we are encountering in the Chennai population or in our patients? So from the African region, it's more of cheilitis glandularis or granulomatous lesions. From the US, it's more of coating of the tongue, whereas from the European side, it's more of ankylosing and fissure. And as far as the surgical clinics are concerned, what we see maximum is mucosal, and the least down is tumors of the nervous tissue. So to summarize, these are the common oral mucosal lesions, what we see in regular dental practice. Traumatic ulcers, aphthous, orofacial granulomatosis, polyps, pyogenic granuloma, epulis. HPV infection is on the rise, either because of an abnormal sexual contact or transmission from a patient who is already HPV positive and then touching the patient's lip or tongue, which induces verruca vulgaris or oral warts, and finally neurofibromatosis. Infections, these are common, viral and fungal. Staphylococcal infection, I'll show you a photo of it, which is called as impetigo. You need to correctly diagnose it because it will mimic a lot of other conditions. Recurrent salivary gland swelling or parotitis is very, very common in children. Initially, you will misdiagnose it as mumps to start with. So episodes will keep on occurring. You tend to manage it medically, but finally by the age the child is 15, 20 or 25, there will be a total atrophy of one salivary gland which needs to be surgically removed. So recurrent parotitis in children and then granula. So coming to the last part of the presentation, let's go through different case scenarios. So this young girl of about 7, 8 or 9 years came to the OP with a complaint of a general weakness, development of bulla or vesicles in the lips which broke open or which collapsed, forming irregular crustaceans or ulcers. It can be peeled off, leading to a bleeding surface. Intraorally, again, it causes vesicles, ulcers with a slough or a pseudomembrane. So when you look at this classical picture, we immediately, anything with the lip with crustaceans or bleedings, the first thing which goes to our mind is erythema multiforme. But this is not erythema multiforme. We'll have to check the temperature of the patient. The patient was pyrexic. So it's some infection which is going on. You do a swab, it comes positive for staphylococcus. So this is what is called as staphylococcus induced infection or impetigo, very, very common in children. It would typically mimic a vesiculobullous lesions, formation of a vesicle bulla which ruptures with irregular ulceration. You need to do a culture. If it's positive, you will have to give the antibiotic with an antipyretic and a supportive, a topical chlorhexidine gel would be good enough for the patient. So within 7 or 10 days, the lesions would have a total healing. So this is one case what you can. This is post-treatment, both the lips as well as the buccal mucosa. Within 7-10 days, the kid is okay. So this young girl of about 10 years came with a complaint of a persistent recurrent swelling of the lips and the gingiva. Not much of pain, but occasional abdominal pain with crustaceans and ulcerations in the lip. So in these kind of cases, when you have a gingival enlargement which is generalized, accompanied with an enlargement of the upper and the lower lip, the condition which should immediately strike to your mind is orofacial granulomatosis, or OFG, or what we call as Crohn's disease. It's a disease of the gastrointestinal tract, the small and the large intestine. The oral manifestation is called as oral Crohn's. And many a times, mouth is the first site where the Crohn's disease develops. Your GIT tract starts from the oral cavity and it goes to the other end. So your mouth is the first site where many a times the Crohn's disease starts, and will present as gingival swelling and lip enlargement. It's difficult to do a biopsy in this case because it is a granulomatous disorder. You have non-caseating granulomas which is found deep within the connective tissue. So surgery is going to be traumatic and it's going to be disfiguring also. That causes a lymphatic obstruction leading to the swelling. So you go with your clinical trial or the clinical presentation or the clinical diagnosis. So the treatment for this patient is a mandatory 12 weeks strict diet control. The 3 things which needs to be avoided is cinnamon, benzoate and chocolates. Of course, kids are going to get offended when you stop them from chocolates. These 3 are the main 3 offending agents: cinnamon, benzoate and the chocolates. You wait for 12 weeks. After a strict dietary regimen control, if the lesion does not regress, then you go for other treatment. The treatment what we do is intralesional steroids. You give either betamethasone or dexamethasone intralesionally. It regresses, but it can flare up. If there is a superficial ulceration,